Okay, we're going to do the blues, but first, I gotta have to tell you, there's a white MP3 thing out there. This is last year's course, so you're welcome to take it. It has 20 hours in this little piece of plastic. I have no idea how they do that. I'm still waiting for the 8 tracks to come back, but that's last year's course.
You have no idea how to do 8 tracks.
You think he's kidding, don't you?
And then this orange guy here is a sample of, audio sample of Emergency Medical Abstracts, Risk Management Monthly, and ED Leadership. Those are 3 of our audio programs. And those of you who saw all those abstracts in that book, that comes from Emergency Medical Abstracts, which has been going on since 1977. 600 journals a month surveyed, 30 papers pulled, abstracted, commented on. They're in a database. You can retrieve them by asking any kind of questions. They're streamable, goes down onto your this, that, whatever those are. And then Risk Management Monthly, it's Greg and I, basically Greg. Greg has reviewed 2,000 legal cases. Most of them are due to his own malpractice, but he was the president of 2 malpractice insurance companies and is actually knowledgeable about the topic, unlike some of the other things we talk about where we don't know what the hell we're talking about.
Exactly.
Can I?
You want to say something?
Yeah, I wanted to make one.
You want to add to the commercial?
No.
Of course not. No, of course not. Nobody would.
I want to just make one last comment about from the last.
Oh, Jesus, you ran over last
I know,
already.
but somebody mentioned this to me, and I thought it was important. You know, the notion of CT scans are dangerous because they cause radiation, and that's of course true, and that's something you can use to talk to people about. But one of the points from the last lecture that I think is really, really important to make is that, in fact, the real harm of CT scan has nothing to do with radiation, and in fact, for that reason, MRI has the potential to be more harmful because it's actually a better test. And so, you know, maybe we should keep that amongst ourselves, but it's really important to understand that the real harms of these great technological things has nothing to do with their direct harms. It's all the secondary ones, and so retreating to other tests like MRI does nothing to solve that.
Did you get that?
Yes.
Patient satisfaction, they come in, they want to know what's going on. I'm even more cynical, skeptical than you are, in a way.
It's kind of hard to believe.
Is the discussion going to move to, do you want to be treated for this tiny PE that we found?
I think if you do that, you've already lost. There's no way to do that. So again, I think we have to have the courage of our conviction, as Mike was saying outside to me before. This is not a question of shared decision making. We should only offer shared decision making when there are 2 choices that are good. And we have to have the courage to say, yeah, it's in my personal interest to do everything, and damn the consequences to my patient, but it's in my patient's interest to do the other. And I'll only say to you that you have enough gray hair that you should be skilled enough to have great patient satisfaction even when you don't do things. You know, we can get, I've been doing this for a long time, you can get really good at convincing people that they don't need this test. The good news is most people are reasonable. Most people, you tell them, oh, I'll go home, sure, I'll come back if it gets worse. And I think, you know, not everybody, there's going to be the outlier who's unhappy, but you know, we got to get skilled at saying, this is not a menu. You don't get the things, you don't say it that way because that's just offensive, but it isn't a menu. They don't get to choose. You offer them the choices that are reasonable, and it's not reasonable to do unnecessary tests.
Let's get to a blue.
Let's do it.
Let's do it.
There are a lot of great questions in here. And sorry, I was trying to categorize them all. I think we'll start with something related to new anticoagulants, because there are about 5 of them in there on new anticoagulants and PCCs in particular. So,
Didn't Billy talk about this?
yeah, but
he obviously
evidently
he
didn't
do a good
clarify.
job.
Yeah.
I think I wrote that chapter too. So evidently that it wasn't clear there. So I think
Start out, young man.
I'm going to start with Should PCCs be used in anticoagulated patients involved in significant MVA? And then I'm going to give a sub-question of when they are hemorrhaging or earlier. So let me send it to, I'm just going to go in. Oh, Jerry has to start? Jerry, send it right to you.
No,
You looked
no.
like you were ready to answer.
Jerry's the guy who ought to deal with this.
Yeah, you're, I guess so. I guess it's not me right now because
I don't
I'm
think
moderating.
anybody knows anything about giving these things prophylactically, and somebody's been beaten up in
Right.
some kind of car accident, and their INR is 5, and say, "Oh, geez, well, maybe we should do this prophylactically." I've never seen any study on that, and I don't think that it probably makes sense, because the fact of the matter is that we have such great technology to determine whether you're bleeding now from hitting your head on something or your belly on something, that I don't think that would be, even if a study was done on it, I would guess that would come out to be not a good thing to do.
And just think of what we've just been talking about before. Whenever you do a therapy, you have to think about what's the potential harm and what's the potential benefit. If you have somebody who's hemorrhaging, the potential benefit is to that patient. It's 1 out of 1. Okay, I could help this patient because if I don't do something, they could be harmed. But if you start doing it in people who aren't hemorrhaging but might be hemorrhaging, many of them won't go on to hemorrhage. So you've now limited the potential benefit and now compared that to the harm. It's like, unless you have a really good therapy that doesn't ever cause harm, you're stacking the decks against yourself. So absent knowledge, we would start to think that the more liberal you are in using it, the less likely it is to be beneficial. Then let's talk about what we know in hemorrhage. And again, there's a lot of literature on this, and Billy already told you about a bunch of it. I want to make it really simple, the way I look at it. Maybe I'm wrong, but the way I look at it is as follows. We have now seen in the last 10 years a whole bunch of new drugs that can make you clot less. They're really good at keeping you from clotting. We've seen a whole bunch of new drugs that are better at making you clot if you're hemorrhaging. We have the technology to do better than the old guys. We can do better than warfarin, and we can do better than vitamin K for sure, or even fresh frozen plasma. The problem is that our homeostatic system is a really fine-tuned system. And if you overshoot in either direction, you can kill a patient really easily. You cause strokes by overclotting, and you cause hemorrhagic deaths by overbleeding. And it's not a surprise to me that all the studies that show benefit from any of these agents all show it based on surrogate markers. It clots better. It bleeds better. But when you actually look at patient-oriented outcomes, most of them are worse for the new drugs. It's astonishing if you think about it that we've had warfarin for 50 years, 70 years now, 60 years. You cannot design a worse drug. This is the drug that interacts with everything, never is in the therapeutic range, screws up all the time, and we can't do better. And the reason we can't do better in patient-oriented outcomes is because the great thing about warfarin is it doesn't work very well. It doesn't affect the system very much. Once you start affecting it a lot, there's hell to pay. So I'm not convinced that I've seen a single study of a single drug in either direction that actually does more good than harm to patients. And mostly I think they do more harm. And that's based on manufacturer studies that don't give us all the information. I'm willing to bet we now know with dabigatran, the more and more started out it was great. And now the more and more we hear, it's terrible. And I bet you the same thing's going to happen with the Pixabans. It might not be true. Maybe one of them will be an advantage, but I don't buy it.
Yeah, the question is surrogate marker. We all know that when 7A came along,
Fabulous.
Fabulous drug. Its only problem, and did it actually on CT scanning show sort of smaller bleeds?
Yes.
Yes, it did. The problem was it was ruined by the fact that the patients were just as bad, maybe worse.
Worse, they were dying more.
They were dying more. And so you can't follow these surrogate markers. I think what we're in the phase in right now is we've got a 5-year shakeout phase where we're going to see some real data come out and some patient-oriented outcomes. We'll answer this question for you in 5 years, and we'll be much better on it.
Well, the other thing is that it's easy to be skeptical. I'm always skeptical. And if you bet on, no, it's no good, you'll be right 99% of the time. One of the problems, though, is that every once in a while somebody actually comes up with something good. It's impossible to tell because there's such hype about all the lousy things that so maybe one of these things will be good. I personally suspect that these pro-clotting agents are not good, but I can't say for sure.
Right. And to be clear, the PCCs right now, as far as I'm concerned, have no role for the dabigatran or the exabans, either rivaroxaban or apixaban. The Hematologic Society has a weak, sort of muddled message about some of that, but the theoretic evidence isn't even good. So I would really, really stay away from those personally.
Although
in that context.
they are working on a kind of reversal agent specifically for the
A reversal
exabans.
agent is, yeah.
And they're working on everything.
Yeah.
And they'll come out with one which will have
Yes,
some surrogate marker, but that doesn't mean it's actually a good
But I
thing.
mean, at least right now, PCC in the face. I mean, with warfarin, someone who's bleeding, I think that's a place where I would strongly consider using it. If they're not bleeding, I would not use it, or you don't know that they're bleeding, I would not use it, and I certainly wouldn't use them in those other drugs where there's not even really a theoretic advantage for using them, and they do cost thousands of dollars per dose. And expose people to side effects. So, okay, that's that. But I'm going to continue on this thread just for a moment, and then I'll switch. And it says, are there any differences we should know about in head trauma patients who are on these variety of different agents? So, and they're talking specific. So, it says Plavix, Coumadin, Exabans, dabigatran, and in particular, I think the person is interested in differences in the onset of bleeding and. Well, that's what's specifically noted, differences in onset of bleeding, and I think I'd also add in there just sort of the general risk of bleeding.
I don't think we know anything about onset of bleeding, but I do know that we have a couple of papers in our database that make it clear that Plavix is more dangerous than being on warfarin when you whack your head. And I don't think most people would intuit that.
I think we just said that this morning in the lecture, that the bottom line of this is you're going to have about 1% of people who may bleed. The problem is we always thought it was less with aspirin, less with procritigrel, all that sort of thing. The answer is no. The procritigrel is as bad as warfarin.
Seems like the worst actor.
It's worse.
The worst actor, yeah, and just be careful. The other thing is, I think we mentioned the paper where 6 hours later they scanned. You know what, if the patient is normal, don't scan them again. Normal is normal. You're not going to find something you're going to treat 6 hours later by repeating that scan.
I'm glad you said that, because that's the other point I wanted to make. There is good news in all of this, which is that you can still treat the patient clinically.
Yep.
And there are people who say, oh, but they had head trauma and they're on a drug, therefore you must do CAT scan, etc. The fact is, we're very good at picking up small abnormalities. Now, early on, we may miss something, but they're going to show it. They're not going to go from normal to dead in 4 minutes. So you have time, and you can watch patients, and the longer they're normal, the slower it's going to be if they do have a problem. In Nexus Head, we found there was an increased risk of real bleeding, not trivial bleeding, real bleeding in people who are on Coumadin or any anticoagulant. But the increased risk was not today, it was tomorrow. So if a person comes in and they're abnormal, by all means do it. I don't care whether they're on Coumadin or not. If they're normal, you're just treating yourself by going searching. What they really need is good follow-up. If you can't do good follow-up, it doesn't matter whether you do
Basically, you say, come back tomorrow.
What you say is come back if it gets worse. You start getting a headache. You start getting confused. Of course, you need. And if they're in a place where they're by themselves and they're old and they're frail and you can, maybe you need to observe them. But the CT scan today won't help you. It's just going to be normal.
By the way,
Or sliver bleed, that doesn't mean anything.
if you ever want to see non-interest, pick up the phone and call a neurosurgeon and say, by the way, maybe there's a little something there and they're on Coumadin. What's the neurosurgeon have to offer you at that moment in time?
Stop the Coumadin.
Stop the Coumadin, exactly.
Well, you know, the interesting thing, too, is there's more and more people on Plavix out there.
You can't stop the Plavix. That's
And then the
worst
question is, well, should we put in new platelets to get rid of these bad platelets and dilute
Because
them
the
down kind of
Plavix will
thing?
ignore those ones.
And it's like you get more and more down the sliding slope of what are you going to do about
And
it?
one of the really bad things about clopidogrel is that when you stop it, they stroke out. It has a very high risk of clotting when it's stopped.
Yep.
So once you start it, you're dead. That's too bad.
Yes.
So is there a consensus on an observation period if the person has no reliable follow-up?
This is a real tough question. It would also depend on the age of the patient and comorbidities and that sort of thing. But no, nobody's got one number that says, oh, in 12 hours it's just fine, that sort of thing.
If you think about it,
You can't do it.
if you bang your head and you have a normal CT scan, you didn't really know, and you had a concussion, you're not really normal. The CT scan can't see that you have little tiny microscopic bleeding and stuff like that. We're all normal, we clot it off and nothing happens. The problem when you're on an anticoagulant is some people don't clot it off. And then it bleeds a little more and it bleeds a little more. Depending upon how fast it's going, they may have a subacute subdural in 12 hours. They might have a chronic subdural in 3 weeks. There's no answer. So unfortunately, follow up, you can't just admit them all to the hospital. If you're really worried, admit them to the hospital for 24 hours. Every 24 hours that goes down, gets less, the risk is less, but they could have it in a week or 2 weeks. You just can't know. Life, we can't be perfect.
So I'll pose it like this then. So if you have a 75-year-old person, typical age, who had a ground level fall and a big egg on their head and has an INR of 3 and is otherwise mentating normally, what do? You send them, you scan their head initially. Let's suppose for a moment that you scan their head initially because there was some question, and that seems reasonable. It's probably fairly standard practice. Do you observe them? Do you discharge them? I mean, I think that this is.
I think it's a question of what their social circumstances. If they have a good family and you can talk to the family, no, you don't need to observe them at all. If, on the other hand, they don't, depending upon how worried you are, and how little help they have and how hard it would be for them to get back, you might keep them overnight.
Yeah.
I wouldn't keep them a couple hours. That's worthless.
At county, that's what we, that's what I do. I don't like to send them home at 2 in the morning with these kind of situations.
Actually, nobody should be sent home at 2 in the morning.
Right.
Well, particularly
I
for-
actually frequently leave at 2 in the morning. So,
No.
And you're happy to be sent
I'm
home.
happy to be going.
You see this all the time, and it's like these people are sick, and it's like they're going home at 2 in the morning. Come on, it's okay.
82.
Everything's better when the sun is out.
Nothing good happens at 2 in the morning.
Exactly.
By the way, in a lot of hospitals, the waiting room is actually the observation unit. You understand that?
Well, I don't think, if you're
Yep.
going to observe someone, I certainly don't think you have to keep them on a cardiac monitor and all that kind of stuff.
And that's a good point. There is a whole literature on cardiac monitors, and so it all
they don't
says
work.
we sent people to OBS, and then we looked. The last 7,000 people we sent, no one had anything. The literature is full of that. So where did this all start from?
Isn't that one of the myths that we talked about?
So it started from CCUs. And why was it? And it worked in CCUs. Why was that? Because when you're having an MI, you're at risk for an arrhythmia. You're at high risk in the first 24 hours. First 24 hours, you put you in a CCU, we see an arrhythmia, it's really important. Or you have cardiac arrest. We treat you, you're better. We've extrapolated that from people who are really at high risk to anyone who's sick. Well, they might have an arrhythmia, let's monitor them. Well, it turns out they're not at any risk for an arrhythmia any more than anybody else. So most of our monitored beds are useless. The monitored bed in the CCU is important. We've just made this crazy extrapolation where it doesn't belong.
Yeah, the literature on it is really pretty compelling that the vast majority of people go to a monitored bed will get no benefit. And to the extent that you are tying up monitored beds at your hospital, because many of the medical staff think they're going to get better care if I send them to a monitored bed. So I'm going to do that. Maybe the nursing ratios may be different or whatever. I would prefer that they go to monitored bed. Their potassium is 3.2, that kind of thing. And the literature just doesn't really support it. But so the hospitals make a resolution to this by making every bed a monitored bed.
All the fancy hospitals in West LA, every single bed is a monitored bed.
Yeah, it is. Every new hospital.
Well, the technology manufacturers are all working on making it all portable monitors.
I bet you every hospital in your hospital is.
And guess what's
bedded
going to
down.
happen when we do this? We'll find
Well, it's
arrhythmias, and then we'll start treating them, and we'll kill people. It'll be great.
All right, let's go.
So yeah, closest to consensus then seems to be no need for a defined period of observation, but let's use some judgment.
But send them
and
home
Not
when
send
the
them
sun
home.
is out.
Yeah, when everybody's going to go fall asleep for the next 12 hours
Right.
and not notice that grandma's not waking up. Okay, the next
But
question.
also
is,
don't send them home with head instructions to wake them every 12 minutes.
Well, that's
See if they're irritable.
Well, that's why you let them sleep in the ED, so that when they go home, if they actually fall asleep.
Yes, exactly.
Have you ever read the head injury instruction forms that
It's
some of
so
these places
stupid.
have? Well,
pinch people and-
Yeah, no, Neil and I got these one time to see what they say. And they go all the way from shake 'em and wake 'em. One said, if the pupils are no longer symmetrical bilaterally. And I said, this is insane. This is just plain
If there's
insanity.
decorticate posture.
If the patient is dead,
Well, that-
yeah, so since he said it, I got to tell the story. So I got to tell a story. Greg just said it.
Take my name.
There was
I just set him up softball.
a malpractice case where a woman who happens to be the school teacher of the year in Utah is in an automobile accident. She has a head injury. They admitted to a hospital in rural Utah where they have no capacity to treat head injury, but they admit her to the monitored bed where the instructions are GCS and neurochecks every hour. And the GCS neurochecks read 11 p.m., GCS 14, 1 a.m., GCS 12, 2 a.m., GCS 9, 7 a.m., GCS 3.
Call house officer when GCS less than 5.
Three. At 8 a.m., the new staff comes in and says, oh, let's call the trauma center to transfer. That's like when the pupil's blown. I don't think the purpose of doing GCS every hour is to document
The
how stupid
deterioration
you
of the
are.
patient.
It was a true story. I mean, like, holy.
Yeah, some of this is
Yeah,
just
we
not that
documented it.
complicated.
We did it every hour.
Right?
I didn't say you'd do anything about it.
Yeah, right.
I did. I followed
You're a
orders.
surgeon, for Christ's sake. All right, what is the consensus regarding post-Roski cooling in patients presenting with VF arrest given new data?
Never has so much time and effort gone into an area where there's so little real data. In fact, this went way out of the
Never?
realm. No, this went way out of the realm of science when, like in New York, they wanted to have Center of Cooling Excellence. They were going to split up
A
the.
Brought to you by
refrigerated
Igloo.
center of excellence.
How many people here from a hospital where this has been pushed, this cooling excellence?
Who do you think is going to admit that when you put
They're
it like that?
always in their hands.
I used to get. I got a series of emails inviting me to come to hypothermia boot camp for a weekend for
Sounds like an
for
enjoyable time.
$400. And I wrote back to the guy who I happen to know,
Bella.
selling this, and I wrote back and I said, I don't understand. What are you going to tell me in 2 hours? Put ice under his arm? It's going to take me a weekend to learn how to put ice under his arm?
It's a multi-day course put on by the University of Pennsylvania twice a year on how to do hypothermia.
I said, I could learn that probably faster than a whole weekend. They said, we will no longer send you invitations.
Here's the problem. We started going on 2 studies, relatively small number of patients. I don't know, kind of look good. Then all of a sudden, it's destroyed by the one decent paper that actually said, you know what? Look at this. Neil Little, and who's one of our faculty member, and his wife is a neuro research genius kind of thing. They kind of looked at all these studies and they wrote a great piece. I'm sure you've read Neil's piece that basically says, we haven't proven crap. Because just because you ran a bottle of cold water into somebody, did you actually lower the temperature of their brain? We don't know any of these things. And
Well,
it's
but
gone
the bottom
crazy.
line is, you know that there's a large study which is just published, which the questioner obviously knows that the large study that was just published said it didn't work. And, no one study is definitive, but this study is certainly more than the 2 studies that claimed it did work. And ultimately, basically, when the 2 little studies were published and said, oh, this is the greatest thing since sliced bread, one of the rules that I try to live by is that you should always use Bayesian reasoning. And Bayesian reasoning means, what was the likelihood before they did this study that this was true? There are 100 studies on using hypothermia for neuroprotection, for sepsis, for head trauma, for cancer, for ICP, for you name it. There's 100 studies. Every single one of them says it doesn't provide neuroprotection. So the chance that this was true, when they had these two little studies that said we did it and they did better, even after the studies, it was very unlikely that it was really going to be true. Now, Rick always used to say, well, so what? It costs nothing to put ice under their arm. And you want to do that, what's the harm? And I have no problem with that. My big problem is making a big deal out of this, making pretense out of it, making hypothermia centers that charge fortunes to do it, when almost certainly it's useless.
I have my first lawsuit for not cooling.
Oh, fabulous.
Well, that'll be an easily defensible lawsuit.
I was going to say the really cool thing about this, but then
Haha.
the good thing about this is that the guy, I think it's the same guy, was brave enough to. He was just about to present at the big Australian conference last year, and he had to stand up and say, "Look, this work I've done, it doesn't work." So it's actually important to.
Which is great and very unusual. The
He
comment he
actually
made
had-
is that one of the people who did one of the two studies was
Aussie study.
scheduled to talk about how important this was. The new paper came out and he said, you know what, I guess I was wrong. My life has been useless.
Oh my God, he's the one man picked from 10,000, believe me. Yeah.
Although, honestly, I do have this kind of point of view that when the stakes are really, really, really high, which means your brain function and your life after you've had a cardiac arrest, that perhaps it allows us to be aggressive in implementing therapy as long as we don't think it's going to hurt anybody. And so we believe that hypothermia was not going to hurt anybody, and if it had a chance to save your brain and save your life, then we would be remiss if we waited 10 years to get the definitive trial on this kind of thing, because in the meantime, all of these other people may have benefited and don't.
And I agree with that, but there's a but. And the but is,
It's a big
as
but.
long as we don't,
very big
as
but.
long as we can't hurt you, and the truth is that we can always hurt you. So until we know it's beneficial, we should never say, but it can't hurt. Why do I say that? So first of all,
I didn't say it can't hurt. We just perceive that there is that it
you have
can't
to have
hurt.
a pretty good reason to think it doesn't hurt. So, and we should be very skeptical about ever saying that. Why is that? First of all, the whole notion of this was we get that back to circulation, but some of them go on to stay comatose. Well, some of them don't. Anything we do could reduce that number just as much as it could help that number. So be very cautious before you say it can't hurt. It could hurt. And what's a good example of that? 2 years ago in the New England Journal, they did a paper, somebody did a study where they did a randomized trial of you have elevated ICP, you're herniating, we've tried everything, your
Still
ICP
too
is
high.
still too high. So you know what? Let's take off half the skull. Maybe that'll allow it to expand. It might be bad, it might not work, it might be good, but it can't hurt. These people are herniating. We've done everything, nothing worse, it can't hurt. What did they find? They're randomized. You got the skull taken off versus you didn't get the skull taken off. And they were right in that this was terrible. In the group where they didn't take the skull off, 90% of them either died or were vegetative. It was terrible. Horrible, horrible condition. When they did take the skull off, 95% died or were vegetative. They took the few people who were going to get better and they cut it in half. No one would have said it could hurt. How could it hurt? You're already desperate.
How can it
But
hurt?
But it
Moving
can hurt.
half of your head and putting it beside
Your skull,
you?
your skull. How can it hurt when these people are
My
so
skull
desperate?
is here,
Yeah.
It's
How
not
could
the
it-
same as putting some ice cubes
No, it
in your
is.
axilla, for
How
Christ's
could
sake.
it hurt when you're so desperately ill? It
Yeah.
can hurt when you're desperately ill.
I'm going to take the other side of this, and that is every time you say yes to something, spend time and effort, you've said no to something else.
Absolutely.
I.e., okay, it doesn't hurt to cool. You tie up nursing staff. You tie up other people. You know what? We got people waiting in the waiting rooms to get things done. It's not that this wasn't a good idea, but now that that a
point.
reasonable paper is out here, I think it's hard to defend doing it when you got a busy
Well, I
emergency
wrote a
department.
column. It's called Hypothermia is on thin ice.
Yes, you did.
Thank you very much.
good.
I thought it was a great title.
I don't want to go against Dr. Hoffman's process.
Why not?
Why not? Why not? Somebody needs to kick him in the shins every once in a while.
But didn't that study show not the question of does hypothermia work, but preventing hypothermia?
Well, yeah.
That's the
That's the
perverse save of that study. The
So-
perverse save of the study was Well, prevent fever, you know.
So
maintain-
one group had 36 and one group had 33, and the people who support hypothermia had all sorts of oh yes but, and one of the buts was, well, both groups were low, so that's good. 36, I mean, come on. The other thing was, well, maybe 33 versus 36 doesn't matter, but what if it was 32? What if you can never have a definitive study. There's always, well, we could have, if we'd done it on Tuesday, maybe it would work. The best evidence, so beforehand, it was very unlikely it was right. And there's a big study which certainly says lowering the thing doesn't work. Yeah, I probably wouldn't boil them. I wouldn't put them in the microwave. But, I think this is probably irrelevant.
By the way, it's ask a different question. If you're going to run that study, you actually have to run the study differently.
Right.
Let them get hot or stay normal.
Exactly.
They didn't ask that.
And you can't extrapolate in this study. That's data mining at its worst.
Well, that
You
was
can't
an
do that.
attempt to save the face for all of these people who
know.
have jumped the gun on this thing
Yeah.
to kind of try to
All these
salvage
people who
it.
jumped
It's a strange.
who didn't want to wait 10 years for the definitive.
I don't blame them one way at all. I really don't.
So there's modest evidence
They-
overall
they-
that fever is not very good for you if you've had a brain insult,
Yes,
including stroke.
that's for sure.
So I would suggest that, if someone has had a terrible neurologic insult, trying to control fever is probably, the hypermetabolic
Absolutely.
state is probably good, and it, to our knowledge, it doesn't cause
Give aspirin.
It doesn't cause problems,
Right.
and I think that applies in these patients who've had a return of spontaneous circulation without neurologic function.
While it's never been
but not-
studied, it's almost certainly true. Unlike for hypothermia, where all the studies say it doesn't protect brain, preventing fever in all the studies shows it does protect brain. So sure, do it.
Right. But certainly this, to me, this is the, this is death knell
You have
for
to disassemble
hypothermia,
all
and I
of
would
those
never do it.
hypothermia centers now.
Yeah, and our center is still a hypothermia center. And of course, it's
Yeah,
spent 4 years or 5 years building up the machinery to be able to put ice cubes into people's arms. Somehow that takes a long time.
Yeah, that
and
was the-
now, of course, the other day, I just had a case of it, and everybody, the nurses were all freaking out about, shouldn't we be putting ice cubes in the arms? And I'm saying no, and that's causing all sorts of problems. And,
At the last
It's
ASAP
fun.
national meeting, they had a table with a guy who's got a cooling helmet for $28,000. He says, this has got to be a part of your program. Just put this thing on that makes you look like a robot. And he says, that'll get the temperature down faster.
And we keep talking about ice cubes on the arm, and the reason for that is that there are only 2 studies which
That's what
compare
they did.
doing it or not doing it, but there's a bunch of studies which compared doing it simply versus doing it in some fancy way, and they had the same results.
Same results.
all right, the next topic, we'll switch a little bit because this is kind of a hot topic in the literature, which is the D-dimer cutoff level. And what? Yes, there's emerging evidence. There's emerging literature saying that, particularly in older people, that D-dimer cutoff of 500, which has been sort of the traditional level, is not correct, and it should be raised. So,
You notice he says older people, and this smart-ass kid looks down the table at us. And I guess that's probably right.
For the right answers.
yeah, I got it now. What's your D-dimer? I think we should take their D-dimers right now.
Yeah.
Presumably, none of you are having a pulmonary embolus, and
Yeah,
we'll
right.
find out what it is.
Right?
So, any thoughts, Rick? D-dimer? Do you want to raise the D-dimer?
Well, I
number?
did see the some formula where you take your age and add it to the D-dimer.
The age
which is-
times 10 is the concept.
Yes, but those papers are they're few and far between, and you'd really, a D-dimer is such that it's going to, if it's positive in terms of your interpretation, it leads you down a path that's pretty aggressive in terms of we're going to do a CT angiogram, those kinds of things. So I'd sure like to see something a little bit more definitive than a paper or two on it, because they don't even come out with the same equation necessarily. Yeah. And so I don't feel comfortable personally with it, but it makes some sense.
Yeah, so the notion is that we want to decrease false positives because there are so many of them. Right. And so that's a good idea, but I think it skips the real question. The real question is, in whom should you do a D-dimer? And that's really the important question. If you start doing, so the notion is as follows, and it's a good notion. If you have a low risk of pulmonary embolism and your D-dimer is normal, you can stop. But the definition of low risk of pulmonary embolism is 8 to 10%. If you start out with a 10% risk you have to do something because 10% is too high. You get a low negative D dimer, you're good. And there it might be you use a different cutoff for different ages. We don't know the answer yet, but maybe that would be a good idea. The problem is when you start out with a 2% risk of PE, which is what all of the studies that are now being published in the North America show. If you look at the low-risk group, it's 2% or less actually ruled in.
Usually less now.
And actually in most of the studies, it's 2% in the whole population. Everybody they did it on, almost nobody rules in. Once you do that, you've not only not done good, you've done massive harm. And there's evidence that when you give this group of people a D-dimer, and these people have to do it clinically, and the whole purpose of a D-dimer is to decrease the number of CT scans in that low-risk patient. This group does twice as many CTs. Why? Because they start doing it in no-risk patients, and then it's positive all the time, and now look what you've done, Ali. You have to do a CT. So the real question is not what cutoff to use, but to stop doing it in no-risk patients. And no risk is anybody who gets into any of these studies. We know that. So we got to go back to, just like we were saying before, you got to go back to being clinically, being willing to say, this isn't a PE. We're not going to start down the path. If you do that and you really say, this person, I don't think they have it, but they have a 10% chance of having it. They really are short of breath. Their vital signs are abnormal. There's something that really, I can't just dismiss it. Then a D-dimer could have very limited use.
Yep. There's no question that if grandma just got off the plane from India, where she was being treated for both her hip fracture and her cancer, do you really care what the D-dimer says? The problem is that low-risk patient who now has a positive D-dimer, you've just screwed yourself. Yeah. You've got to work that patient up.
Right. Well, okay, so I guess this is stemming from, I think it was in the Lancet, right, or something, or BMJ or something. There was this new trial, or new study, it wasn't a trial, and I think that's actually really important in this context. So they looked at a bunch of old people who got D-dimers, and they threw in different cut points. If they did their age times 10, so if you're 70, your cut point was 700, and if you're, and then they also looked at a cut point of 1,000 in general, and they found that the age, I think in that particular one, the age times 10 was a little bit better than the cut point of 1,000. I think that it's important not to adopt this right now, and I think it's important on both ends. One, Rick said that this is still kind of preliminary. We don't have big stuff. It's in a big journal. You might be able to sort of intellectually justify it, and if you got into trouble, you might be able to justify it on the basis of that. But that's still one reason I wouldn't do it. It's still pretty early. The other reason is getting back to what Jerry said, which is it gives you a false sense that some old person who you might not have ordered a D-dimer before because the risk of false positivity is too high, and you're like, I'm not going to walk down that pathway because 80% of them have abnormal D-dimers, which is generally what they find. So instead, you feel emboldened to use it on a lower and lower risk population because you think that you're going to be able to use a higher cut point and not have to go down the pathway. But by using it in that broader and broader population, which is the entire history of D-dimers, every time we've had this test, every time anyone said, oh, it's okay, it's going to allow you to rule out people, all it does is have us broaden the net, or widen the net, and then we end up going down this pathway a million times. So right. I think there's two reasons not to adopt this new cut point yet. I think it's likely. I'd love to see a trial that said, let's give this cut point versus another cut point and see what actually happened. Do we see more people enroll into the study who are getting the higher cut point or not? And we're just not there, so I don't think it's ready for prime time.
But the big thing is that the D-dimer should only help you once in a blue moon. You shouldn't be ordering it very often. You should be ordering it only in that patient where you say, you know what, I don't think this person has it, but I got to do a CT scan because the risk is just too high to ignore. That's a true low-risk patient, and that should be that 1 out of 10 of them actually has the disease. And if you're doing it in that person, it could occasionally save you a test. Most of the time it'll be positive and it won't help you, but occasionally it'll save you a test. But if you're doing it in, they don't have it, but I have this easy test, a D-dimer, that'll make me feel better, then you're only going to do harm.
Well, and I counsel the residents, I'm sure you guys, or you do too, Jerry, but every time you order a D-dimer test, you have to go through the mental exercise. I do it myself with the residents and myself when I'm seeing patients by myself. If the lab called me right now and said the D-dimer machine is broken,
Would I do a CT scan?
Would I do the CT?
I
And
think
if
I
the
was-
answer is no,
Did
I don't think
did
so.
I teach you that?
No, I
think I
taught you
taught
that. That was-
No.
That's impossible.
No. He was
Agree
my
to disagree.
resident. I'm allowed
But
to.
the point is,
Tease
the
him.
point is,
There's
you
a
really have
question.
to do that.
So I heard that Jeff Klein talked about modified level depending on the pretest risk. Has that been released any or published anything about that regard? Because
Just-
a patient with the level's 570, it's
Right.
appropriately screened, has some risk factors, would like to use it, but it's just outside the normal range. They have some risk, has he published anything about that, or have you heard anything?
To my knowledge, I have not seen
I
those
certainly heard him
publications.
say it,
Yeah.
and I don't know if there's certainly no data about it. He may have written it, but I think all the comments that Mike just made are still true. We don't have evidence for it, and there is unintended consequences of doing that. Oh, I can get the D-dimer because this way I'll be able to judge it. And then once it's high, and now what do you do? But it's really hard once it's high to say, well, I didn't really need it in the first place. I didn't really think he had it, so I'm going to ignore it. I don't think that's the way to go. I think the way to go is to say, just what Mike said before, there is no D-dimer. This patient really needs a CT scan. Okay.
Yeah, but
now
they're
I
not
can consider it.
hypotensive. Fine, order the D-dimer in that case, and otherwise just throw it away. And I know it's unsettling now because half of the time these D-dimers come back before you've seen the patient. It's.
But
really
yeah,
a
well,
problem.
I was just going to comment. Nobody ought to be ordering a D-dimer in advance of you. I mean, this is not one of those things where we're going to order it in triage.
It really is like ordering a CT scan.
Under any
It's like
criteria.
ordering a CT scan. But
Contrast CT
but the
scan,
same
yes.
the same thing that's really important from that comment is, if you think you're going to speed things up by having set orders at triage, you got it completely wrong. It's only going to cause us harm.
Exactly.
What should be ordered at triage should be minimal. Maybe a urine in
Pregnancy
somebody
test.
who's got urinary symptoms. Maybe some pain medicines. But the more we tell people to order without thinking, the more we're going to end up, oh, the test's positive, now what do I do?
Although there's also some imaging that can be done, obviously.
Ankle film.
Those kinds of things.
Very
Pretty
limited
minimal.
stuff.
But
Pretty minimal.
you see these people come in with abdominal pain, and
Yeah.
they have this order set. As soon as you hear the word order set, makes me real nervous because an order set means at least $1,000 worth of tests being checked off because you're just too busy to decide which test.
Well, but
should be
even
done.
worse, it means that you're going to have positives that now you have to do a workup in somebody who
Well,
doesn't need it.
I think that physicians get paid to make a decision about what
Yes.
tests are appropriate. And the idea of having order sets that are initiated by somebody out at the triage desk is just a mistake.
Well, unless they're a provider. Provider at triage is okay for me.
But even
Provider.
well,
Well, they should probably take care of the patient.
even that is really bad because if you're set up triage and you're there because we're busy and there's delays and we want to get things started early, nobody's going to yell at you for ordering things, but they're going to come back to you and say, why didn't you get the CT on this person? So you're going to naturally go to over-ordering, and that's only going to cause harm. Unless you're the person who's responsible for the patient, you shouldn't be doing the.
I think by nature, order sets are going to be over-ordering. They're going to be created by committee, and they're going to get, well, I had this, I had that too, okay. All right.
All right, management of acute psychosis. What are the drugs of choice? Haldol, et cetera,
Pretty good.
Geodon, atypical antipsychotics, et cetera. So,
I'm not aware of any.
we're a center of
head-to-head.
excellence for agitated patients at LA County.
I'm not sure of any head-to-heads that this drug works better than that drug works better than that drug.
Oh, no,
The new drugs never have
Yeah.
head-to-heads because they can't help them.
There's certainly never been assessed in
Droperidol is probably
truly
best
agitated
of the
psychotic
drugs that we
patient.
commonly have access
If
to.
you have if you have an old drug that works and you have a new drug and you compare the two, nothing good can happen. Either you win, okay, that's good, but you can win without a trial, or you lose, you're not as good as, or you're not better than, now you've screwed everything. So it's much better if you have a new drug, not to say, let's test if it's better. What you want to do instead is say, here's all the reasons why it has to be better. Theoretical reasons, less side effects, more convenient, I can give it quicker, its half-life is less. So there are no trials comparing the drugs. All the drugs we use are good. They all work. I would never use the new fancy ones. They're more expensive, and there probably are side effects that we don't know about. But the old drugs all worked really well. You just have to know that with drugs like droperidol, which is probably the best, or haloperidol, which is really,
What's
really good,
droperidol?
or a benzodiazepine, you got to give enough. And in fact, for rapid neuroleptization, that means big doses sometimes, depending upon what it is. I lived at Mike's place 40 years ago in the 70s, where it was PCP Central. And we had 5 major Rick remembers, overdoses every day.
It's the call room.
And when you had those, you gave them lots and lots and lots of Haldol. You gave them 30, 40, 50 milligrams if necessary, because they were sick. And it works. It takes a half hour and it works.
And we do have a study in the database comparing Haldol and droperidol. And droperidol, it tends to be consistently better than Haldol, except it'll kill you now because it does something
It's
with
a
your
black box.
QT interval. But you know that.
But so do all the
that's-
atypicals all have black box warnings now too.
Everything does. And Haldol does too, but Haldol is not subject to the same things that
Yeah,
droperidol is.
this
Amazing.
silly measuring of the rhythm strips is kind of like. I hope you don't do that.
So who is using haloperidol right now for the management?
Vitamin H.
And how many are using some of the newer things,
What do you use?
Geodon.
et cetera? Olanzapine, Zyprexa, yeah.
Yep.
Yeah, so there was I don't know, it's probably been almost 8-10 years that there were a series of articles that came out claiming that those were superior to Haldol, that, the trials at that time were really, really dubious. They weren't really superior, and they weren't really in the patients that we're talking about either.
Oh,
These
and
were consenting
overall, by the
patients.
way, the use of these drugs have been, now there is evidence about their overall long-term side
Right.
effects. Haldol is so bad because of tardive dyskinesia, there's no difference in side
No
effects.
difference. And in fact, there's a much higher incidence of cardiac mortality
Yes.
with patients who are on atypical antipsychotics, the Zyprexas and
All the atypical antipsychotics and all the atypical antidepressants, none of them have advantage.
Yeah,
By the
so-
way, whenever you want to
Except they
run
cost
a sham study on these things, what they did 10 years ago was a lot of the new stuff, a certain dose was given, and then they underdosed
2 milligrams of Haldol.
2 milligrams of Haldol. You and I know that in the
citing
first
cardiac fear and
yeah,
such.
the first blow dart has 5 or 10 in it, and how much did we give? As much as we needed.
And rapid neuroleptization, don't misread this, doesn't mean you start out at 30. It means you give
No.
5, 5, 5, 5, but you do it quickly and you go up till you got it.
Yeah, exactly right. But that's how those papers are all done. It's just like with pain medicine. You always look at the dose they started with in these things, and oftentimes they start with a basic inadequate dose on the old medicines.
Ketorolac was just as good as Demerol when the Demerol was 5 milligrams.
Right.
Yeah, so for our
5
money at
milligrams
county,
is 1/10 of a useless dose. 50 is useless. 5 milligrams was the study which compared it to Ketorolac.
Exactly.
so yeah, 10 of Haldol, that's the answer.
Yeah, that's the answer.
10 of Haldol.
But benzos work great too.
And 2 of
Benzos work
Ativan.
great too.
And you can throw on Benadryl or Cogentin if you want, but I don't. Okay, so next, regarding management of pain for femoral neck fractures, comparisons of PCA, morphine, just standard dosing, or femoral nerve block. Anybody doing?
I have a
femoral
lot of
nerve blocks?
experience with that. I do. I've used a lot of femoral nerve blocks. You need morphine too, but it's good. I
Femoral
like it.
nerve
It makes them
block.
feel better.
I don't think it's an either or.
Yeah.
It's just-
Exactly. The other thing is it's way underused in this country. The sort of anatomic knowledge of our students, I think, is going down. If you ask them to point to this or that, it's harder.
The hip.
Like the hip?
the shoulder, the shoulder.
But of
Yeah.
course, we're in America where we think Canada is a city. So
Yeah, right, exactly. But
Isn't that true?
but I'll
no,
tell
it's
you,
a state.
if you're gonna
Canada.
send Grandma over to have her hip X-rayed, put the medication in. It's simple to put in. It's an easy space to hit. You can always add other stuff to it, and I think you balance those two, and it's just fine.
I will just mention that there was a few years ago, there were some studies which used this other place. You don't go in at the femoral nerve, you go laterally, and you go in and you let it diffuse, and it was going to avoid all of the bad structures in the groin. And I tried it, the first 3 times I tried it had absolutely no effect at all. I stopped trying it. Femoral nerve block is great. You should get good at it. It's really good, like many, many other things, but it's not adequate. You need to also give them morphine. I don't.
So
I
we're
don't.
seeing a
you
huge
should.
resurgence of it at our institution because because of ultrasound, and the ultrasound aficionados have taken this as one of their calls to do more nerve blocks. So
It probably is a good idea, but it's really hard to miss. So, and I don't think you cause harm. You know, if you're careful, if you start getting paresthesias, you move a little bit away, because what you're really hoping is for diffusion. You don't want to go right into the
Exactly.
nerve. So I don't think you need it, but sure, if you have ultrasound, do it, sure. And you have to know how to use the ultrasound, which excludes
well,
us.
yeah, I just I don't actually know how to. I have great.
We know
white
how to
color
check the
blindness.
box.
You know how to have somebody who does know.
Yeah, I know how my residents are like, that's the nerve. I'm like, okay, put the needle next to it. Okay. Good job. Good job. All right, next
I love
is,
it when they say to me, "Is this the?"
Yes,
I like
probably.
it could be.
no, compress it. Is it compressible? And they're like, no, it's not. That must be it. I'm like, yeah, whatever you said. I'm a reluctant ultrasonographer, to say the least. Okay, so I think that's good. Yeah, morphine plus femoral nerve block is good. I think that people should do more femoral nerve blocks in these contexts. It's benign, and we're often underdosing these 80-year-old people who are. Who have
Rib blocks are another really good thing. Rib fractures really, really hurt. People can't breathe. They can't move. Do a rib block. It's really, really a good thing. There are
use ultrasound.
many local blocks are terrific.
One of the local blocks I really like now is if you've got a patient who is pretty heavy into drugs and alcohol and now has dislocated his shoulder, I found
Go
that
into
you can't miss that spot.
Right.
And you put the
Where
medication
nothing else
in
is, that's where
Wait,
you
what
go.
spot are we talking about here?
right there.
Oh,
I think
just
there's even
intra-articular,
a
okay.
vacuum.
Some people are
Put it
doing
in-
scaling blocks.
No, just put it in interarticulately.
I think that's crazy.
Put 10 or 15 cc's in, let it sit for a while, and you know what? You can put that shoulder back in, and you don't run the risk then, as if you're giving other medications of dealing with their alcohol, whatever the drugs they've got on. But these tend to be young males, 18 to 30, and it works just fine.
So now we've got one about renal colic. And so we'll talk about renal colic for a second. The questions are, what about intravenous fluid for renal colic?
No.
What about
No.
alpha blockers for renal colic?
No.
No,
And what about CT imaging for renal
No.
colic?
no.
Like that, wow.
No.
Strike three.
Next question.
No, we're being.
And
we're
I didn't
being
even have to
flippant.
say anything.
No,
And
we're
those
being
are,
flippant.
now we can spend 10 minutes saying why those are the right
Yeah,
answers.
yeah, okay, go
But
ahead.
they are the right answers. Well, if you have a blocked kidney with a stone, the fluid goes out the other kidney. You're just doing calisthenics on the good kidney because it's blocked up. It's not like it's like you're washing down the driveway. The more fluid we put in, the more we'll flush that stone out. That doesn't exist. So that fluids is no. Yet everybody does it, but it's no. In fact, there's some literature that
Because it's
says
some
they'll do
pain.
better if they're dry on the dry side. So, and what was the second question?
The
Alpha blockers.
Flomax, alpha blockers.
They were. It's kind of like hypothermia.
Yeah, this
It
is
really
going
worked
the
it
same pattern of many other
I
diseases.
love it because Rick always disagrees with me until the definitive paper comes out. Oh, yes, it's good. Did you say that?
Yeah.
Were you wrong?
Well, I think, but this is one of those issues where
It's not that I'm smart. I just know if you say no,
he
you're
keeps
always
on-
right.
Yeah, exactly. But the idea here is that there is some potential downside in terms of causing hypotension, and particularly if these people are older. So it doesn't go along with my philosophy that says you got to believe that there's no downside and there's only an upside, and the stakes are really high.
So
they're not high here.
Urology climbed on board on this early on.
Yeah, they did.
The urologists believed it, and now all over the map, there are those guys who say, don't do it. Charlie's going to go out and fall over and get hurt. I still have a few people who like it. I'm not a hard guy on this issue. If this particular urologist wants it, okay. But there's no definitive data that says that this stuff makes kidney stones pass faster. It just doesn't.
What a great name, Flomax. The guy who came up with that name, he got a nice bonus, Flomax.
So just to back up for 1 second, one of the concepts that we keep talking about is whether you use the precautionary principle. And the precautionary principle says don't do something until you know benefit is greater than harm. Until we have really pretty good evidence that benefit's greater than harm. That's very different than the idea of, well, let's try it. And you have to try it somehow, or you'll never learn, but that should be in a study. So I think as a general rule, we should be very cautious about doing things where there isn't good evidence that it actually helps, because we can do lots and lots of harm. And so with this, the trajectory is just like with so many other things where it's fabulous, isn't
Initial
it? Oh,
small
it's not,
studies.
It's not fabulous, but it's pretty good. Oh, it makes it less recurrence, or it passes faster, or, well, but if it's a big stone, it does. Well, not a big stone, but if it's Tuesday, it does. The sum of the evidence now is it doesn't work. So
Although
it does cause harm.
Although to be fair, there is this belief that it takes a long time to get known therapy broadly disseminated. And one of the great examples of that was thrombolytic therapy, which took 10 years to be broadly embraced by the medical community. And one of the problems is that was turned out to be really important therapy. And people during this 10-year period, who 9 years, 8 years, 7 years, never got it when that process should have been accelerated.
There's a difference between saying when we know something is useful, we should try really hard to make sure people start doing it, and saying, we don't really know yet, but it looks pretty good, let's try it. Those are two very different things. So let's be very clear about them. And what we're talking about here is there are always very small studies which claim to show something's wonderful. We should be very skeptical when you see that, because most of the time, as it turns out, when it gets repeated, it's not wonderful.
By the way, before we leave stones, the therapy for stones, I think morphine is just fine for the pain. I'm a guy with stones. There's nothing as good as NSAIDs. And NSAIDs do work on hollow viscous pain. It is useful. I can't think of a time when I really want to give anybody ketorolac except for that. Myself, personally, morphine helped a little bit. Ketorolac, in 10 minutes, it was gone.
Although this is kind of like the hip thing. It's not one or the other.
It's not one or the other.
You can do both.
Yep.
So I've had the great pleasure of
Fasten your
having
seatbelt.
kidney stones as well, and are you kidding? Morphine is what works. Morphine is what for
Are
me.
you kidding?
And the literature is, I don't think, would support that the NSAIDs are great. They're okay, and they take 20 minutes to work, and morphine takes 5 minutes to work. So I personally, we each have different experiences, but
Different stones.
The literature I think suggests that you really need to bomb people with opiates, and that you should start an NSAID soon. And personally, I never use ketorolac. There's no reason to use it. Treat their pain, and then start with an oral opiate once you've gotten their pain under control.
Oral NSAID.
An oral NSAID once you've got their pain under control.
But once you start an IV,
Oh, and then the other thing was...
IV's there. You're going to use IV ketorolac.
I don't. The other thing is, the question was CT scans. Why did you guys say no about CT scans?
Well, I think if you've had your initial, here's what you got to look at is this guy in with his fifth stone, and you look back at the previous CT scans, first time, first stone, how do you know they're not dissecting their aorta at that moment in time? By the way,
Because they're 30.
Well, let's say that they're 50. I want the scan
they're
the
50.
first
You
time.
have Marfan's.
After that,
Still have to be.
okay,
Very
6
unusual
months later,
dissection.
they're back in with their same stone pain. I just go ahead and treat it without a CT scan, see if they got better.
So yes and no, I would just disagree slightly. So for sure, you don't need to keep repeating CT scans, that's for sure. And for sure, it's not a big deal if you get one the first time to know what it is. But I would just say a little bit that the notion that you're going to miss an aortic aneurysm and you're going to confuse it with this is based on very poor evidence. It's based on the notion that, well, it turns out when people did miss an aortic aneurysm, they sometimes thought it was a kidney stone. Well, yeah, that is possible, but they look very different. And you've all done a million of these in 60-year-olds. How many times have you been like, oh my God, it wasn't a stone at all, it was an aortic aneurysm? No, that's very, very rare. They look very different. Kidney stone is a doorway diagnosis. I remember, these guys remember, when we didn't have CT scan, you walk in the room and, yes, that's a stone. And that's what a stone is. It's very, very clinically obvious. So if there's a question, you're not sure, of course. The tests aren't bad by themselves when they're done appropriately, but doing them randomly or routinely is where we get into trouble. Most of the time, I don't think we learn very much from a CT scan. If you want to do it on the first stone in a 60-year-old, okay, but mostly it's unnecessary.
Yeah, I don't think there's any question you ought to do it the first time. But however, we have a paper that looked at the fact that CT scans often get repeated. There was one case, 37 CT scans for kidney stones. This was radiation therapy for kidney stones.
Yeah, right.
They were trying to dissolve them by rads or something like that. But you know, well, you saw them one time, your colleague sees them next time. The urologists basically have a recommendation. The recommendation is flat plate and ultrasound. Flat plate, you know, is what we used to do in the Stone Age for.
But radiologists also had a CT recommendation for a long time
Who
too.
did?
The radiologists,
Had a
the urologists. Sorry, they also had they've had lots of CT first stones, CT repeat stones. So there's just a tide turning against it because it's so low yield.
Well, actually,
so useless.
I thought the Urologic Association was basically on recurrent stones. If you want to do any imaging, do a flat plate and
recurrent.
ultrasound.
Recurrent.
Recurrent.
Yeah, so I mean I agree with everything that's been said, except that I don't scan a first-time stone if it looks like a stone and smells like a stone. I think it's important to not relinquish that ability to diagnose simple conditions to a CT scanner.
I
mean,
agree completely.
And I teach it and I do it, and that's the way it is. If a guy has a stone and you do it,
And we did it for years before there were CT
Yeah,
scans. And
30
it was
is
no big
one
deal.
thing,
I didn't
60
do
something else.
You didn't do
again,
IVPs and
if-
everybody.
If the diagnosis is in doubt, that's a different
If you
situation.
were to ask,
Most people would agree with you, Rick, but
Thank
some
you.
of us don't.
Yeah.
What about the potential for people with a high-grade obstruction, big hydronephrosis,
Sure.
potential for infection behind the stone? I mean, I just did a CME risk management thing for a well-known
Sure.
emergency medicine group.
Sure.
And I missed that question because that was the answer. No,
Yeah,
this
so-
scan of this person has to be admitted.
Yeah.
Someone has to be admitted for hydronephrosis, is what they were claiming?
So it turns out that, so first of all, hydronephrosis is only dangerous if it lasts for weeks. And hydronephrosis is not clinically silent if it lasts for weeks. So if the patient's not getting better, they still have problems. If stone passes, you're done. And by the way we make stone pass is by getting rid of the spasm. And the way we get rid of the spasm is by getting rid of the pain. And NSAIDs too, probably. So it doesn't matter if they're hydronephrotic now. What matters is, do you treat them or not? You've got plenty of time to figure that out later. It's not getting better or it is. Early on, that's not an issue. There's no harm from hydronephrosis until it's been weeks before it affects the kidney. And in terms of infection, colleagues of mine just published a paper which said we did all these tests in everybody, and I don't know what it was, 15%, 5% maybe, turned out to have positive urine, and they often didn't have a positive urine culture. And therefore, we need to do urine culture in every kidney stone, which is sort of a little... If that were true, and we never did this for the last 12 generations, we've killed all sorts of people who got infected stones, but it never happened. There are none of them. It can't be true. And we also know that a lot of positive urines are not positive. They're just asymptomatic bacteria, true and unrelated. So I think this is crazy. I think basically treat them clinically. Don't worry about that. The patient's not getting better. Now you start doing a workup.
Yeah.
The
And
other issue was just, they were, on this CME thing, it was, oh no, this person has an infection behind this obstruction, and they're gonna get septic, and it's a whole big.
If the patient looks infected, it is a big deal.
When
If they
they're-
look
yeah,
fine-
an infected, obstructed stone usually gets real sick real fast. I mean, we're talking in space of, minutes to hour, they're looking like death.
And that's been my experience on this test.
Right.
I think that your
That's
experience
probably
is more
another,
correct
It's
than
probably
that
another
test.
example of overdiagnosis. If you go looking for it, you will find bacteria sometimes. It's unimportant because none of those people get sick. But if we find it, then we treat it, and then we say, look, didn't we do the right thing? I don't think that's right.
No, I think that.
And 10% of people who have stones have no red cells in their urine. So that is not the definitive, the sine qua non of the disease.
Sure.
All right. So the next one is totally different. But I like it. It's do we need to actually fill out AMA sheets? I know Greg has no opinion on this anymore. So this is, I guess, any more for people who don't want admission or testing, or can we just document in the charts that we
Yes.
discussed it, and is that legally acceptable? And I think this is an interesting topic generally. So I will defer to you, Greg, for a moment about the utility of AMA sheets. And
The AMA sheet that your hospital has is just a record for you to put down the important points. If you put them down in the chart, it's the same thing. I've never seen a defense problem of ours that had to do with did or did not they have a separate sheet. It's whether you hit the 5 points. If you hit the points, that's what's important. It's not whether you have a separate sheet of paper. By the way, these should be pretty good dictations. I mean, you really do need hit. Here's the elements on which physicians have gone down. It's very simple. If you hit all of them, I've never seen a physician lose in court.
But on the other hand, an AMA form can do harm. So it can do harm in two ways. One is it can show that the patient wasn't competent to make an informed decision. There's a scrawl on there that's completely different than their usual handwriting.
Yep.
What does this show? It shows psychomotor impairment. There's a famous case of that where
Yes.
a guy, where they had it in court, they blew it up. Here's his normal signature. Here's this little scrawl he wrote when he said, I'm going home. He obviously was impaired.
This is where you have real problems. If the nursing note and the doctor note do not coincide, if the nurse said stumbling around slurred speech, and yours says, I want to get the guy out of here, he's fine, don't have two stories on this chart. That never goes well.
The other thing I would say that is even more likely to be harmful about an AMA form is it puts you up into a combative relationship with your patient. What you should want to say is, look, I think you need to come in the hospital. You don't want to come in the hospital. You've made a decision. I can't overrule you because you are competent. I've documented all that. What I want to tell you is, look, I hope if you change your mind, you'll come back. We're still here. If anything changes, we're here. Please. You don't want to be saying, okay, well, it's your fault. You didn't do it. Sign here and be done with you. That's what the message is of an AMA form. So I know you can do it better than that, and I don't think the form is the devil, but it doesn't add anything. What you need is not that the patient signed, but that you documented that they were informed of what you wanted, what's the problem with the other one, blah, 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 and critically important, that you say they were capable of making an informed decision. That's what you have to document.
By the way, there's a brand new case decided, Kowalski Case, which was just decided in the New York Supreme Court, that actually looked at that question for an emergency department letting someone go home, and because of the way the charting took place, the ER docs were exonerated and said, yes, this guy did not meet the criteria where we had a right to hold them. You can't just hold people against their will. You've got to show that they constitute a danger to self or others by virtue of a medical condition.
And that they're not capable of making an informed decision.
They can't make a decision.
If the patient's capable, I have to go feed the cat, I know I'm having a heart attack, they're allowed to do that. You're allowed to be stupid, you're just not allowed. But if he's hypotensive and not thinking and confused, then you can't do it.
Yep.
Wasn't this a case where the person went out and subsequently had some harm done to?
Yes. This is a difficult case. The Kowalski case had to do with a guy, and I've handled an inordinate number of these cases. This guy went out, and not only did he leave the hospital, but they think he probably drank again, crossed a street, and was hit by a car. So now he's a quadriplegic. Now they'd like $20 million to take care of him.
Because you let him out of the hospital.
Because you let him out of the hospital. And you know what? That doesn't make good legal thinking to say, well, on that basis, I should keep everybody in the hospital.
That's bad judgment.
Because they have bad judgment. You know what? I mean, bad judgment
Those are our
it's
people.
everywhere. Those are our people. Exactly. But I think the other thing is, if you have family members there, involve them in the discussion and have them put their name down or put their names down, Mrs. So-and-so. They'll be your witness that you tried to take care of this patient.
You know,
And the
bad
family
things
didn't do it.
Well, bad things happen in court, and so whatever you do, they, you know, later on, bad things happen. They may say, "No, he never told me." Whatever. The best you can do is your best. There's no way to be 100% sure, and especially in the American legal system. It's a crazy system, but what you need to do is document you did the right thing. That's the way you protect yourself. It has nothing to do with what they signed or didn't sign.
Right.
Personally, I don't like having them sign the thing. I think it's confrontational and unnecessary.
By the way, there are urban myths. One urban myth is if you sign them out AMA, their insurance doesn't cover it. Lie. Total lie. Our group has been doing this, looking at this question for 38 years or whatever it is. Insurance doesn't care whether you have AMA or not AMA on that chart. So it has nothing to do with payment for the visit.
Oh, I was just going to say that I like what you just said, Jerry, that you have to do your best. And I think we really have to do our best in these cases. And it's a bit of a paradox I find myself in a lot, which is the person who's AMAing is the person I often feel I'm doing my worst with. You know, I'm not connecting with them. I don't like them. They don't like me. And I have this natural tendency to just say, let's just break this and get you out of here. And you have to really fight against that, and sit there and, you know, become dispassionate and metacognate or whatever, you know, people who do yoga and all that kind of stuff.
Right, no, but it's a really good point.
And really do your best to try to re-engage this person around a therapeutic relationship instead of the toxic relationship that has usually developed by that point.
So is metacognate anything like conscious uncoupling?
No, I don't. I'm
know what
not
he
familiar
means.
with
I know exactly what
Gwyneth's.
he means. But
It means a step back from yourself. And
But actually, in some of those cases, it is a good idea where you are having a problem with a person to just move out and have somebody else come in.
So-
Once you've kind of
So one of the things I always tell residents is
yeah, here, colleague, I'm having a real hard problem with this drug addict over there who has a fever, and here you go, Rick.
No.
I'm going on break.
Dr. Mallon will do
I'm
it.
calling.
But I think the rule is for me is, you know, I always try to tell residents that when people are acting inappropriate and being nasty, the most important thing you do is not take it personally. They're calling you names. It has nothing to do with you. They don't know you. You're trying your best. But they sometimes...
The nurses are usually involved at this point, too.
So it's
and you have to
really important
de-escalate.
not to take it personally. And when you start noticing that you don't like a patient, you're taking it personally. The moment you start doing that, you should realize you're about to make a mistake. It's true of all of us. We make bad judgment when we don't like the person. Sometimes you can get help, sometimes you can't. If you can't get help, you got to step back and do what Mike said and say, look, I can't let this person do that to me. They're trying to push your buttons. They're looking really hard to push your buttons, and you got to say, no, I'm not doing it. I'm not getting into this with you. It's not about me. It's about you. You're upset. So I'm going to try to take care of you.
And I will say that several times I've actually gone in afterwards and apologized for my behavior to a patient and said, you know, I'm really sorry we got off to a really bad, on a really bad foot. I didn't mean anything, and I don't, I'm having a bad day. And, I probably was, and they certainly were not helping. But, just by taking that responsibility onto myself, it's amazing. This doesn't happen, all the time, and it's hard to do. It's hard for me to do with, because of my large ego. But when I do that, it's amazing how often that just diffuses the situation right away. And they may still choose to AMA, and they may be able to tell you why, and it has to do with a cat. And sometimes you can help them, feed their cat all of a sudden, and it's like it's not that big of a deal. You could just call their daughter, but they're embarrassed or whatever, and you
my
get there.
favorite. So in the old days, in my more recent practice, I'm proactive and I go see the patients before any resident does. But in the old days, I used to do what most attendings did, which was I would wait for the residents to present. So when I would often get called when there was a problem, and my favorite would be the place is busy, the patient's obnoxious, the patient has been waiting 2 hours and 30 minutes. I get called in because they're screaming between the resident and the patient. The patient says, I've been waiting 4 hours. And the resident says, you haven't been waiting 4 hours, you've been waiting 2 hours and 23 minutes exactly. It's like, this is crazy. This is crazy. Yes, exactly. Who cares whether it's...
My response to that is, 4 hours to see a doctor as famous as me is not bad.
So my response is go see Greg. No, my response is I'm really sorry you've had to wait. Okay, now I'm here to see you. Let's see what we can do for you. And as Mike just said, you all know this. When you are nice to people, when you say I'm sorry, I'm not sorry that I was bad. I wasn't bad. I'm sorry you had to wait. I am sorry you had to wait. As soon as you say that, the vast majority of people become puppies.
It's incredibly disarming to them.
I
Usually.
go
They
on a-
Actually, some people suggest that you say, I'm sorry you had to wait for every person that you see. You walk in the door, I'm
Just
Dr.
say it.
So-and-so, I'm sorry if you had to wait.
And
say,
they
"Oh,
almost
no,
always say,
it was only
yes.
10 minutes.
Oh, yeah, no,
You
no,
just
no, go-
apologize for the wait right away, and it's a wonderful technique to kind of ingratiate yourself.
So, yeah, and most of those people, I always like to use the example. How many of you have ever been cut off on the freeway?
Generally by,
How many, when you've been cut off, want to kill the person? And how many where the person looks and goes, oh, and they, like, I'm sorry, oh, I didn't see you. As soon as they do that, you can't be angry anymore. It's impossible.
Unless they're flashing you this, and then you're angry.
I didn't say this.
details.
Yeah. Gentlemen, I think we're done.
No, come on, we have a couple more minutes yet.
Okay.
This is fun.
Do we have any more left?
No, there's a ton left.
That's right, that's because the prize is so fabulous.
All right, I think this will be the last one. I'll do this because it's interesting and controversial. So someone wrote, cyclical vomiting, WTF. Is this real, or is this restless leg syndrome of the abdomen? What does it have to do with marijuana? And I
think that's not. I think you got to get rid of that one.
No, I like this one. I like it because I think that the question that's being asked here, or at least the question that comes up a lot for us clinically, is these weird, pain syndromes that we don't have an underlying, a clear pathophysiologic understanding of. Sort of how do we deal with that? And I think cyclical. I personally would agree with the restless leg syndrome of the abdomen, or the chronic migraine, or whatever, or a non-specific headache that just is debilitating and painful and all that kind of stuff. And it seems to me that every region of the body has one of these syndromes, intestinal angina, et cetera, that we can't really understand. And how do we approach a patient with that kind of thing when there's no objective evidence of severe pain, and yet?
So what do? You like
No,
this
I-
one? Answer it.
You picked
No.
the question, Chief.
Oh, so what do? I treat their pain like any other acute painful condition. So I treat it, generally speaking, with acute morphine. So going through this, I do think that this is a restless leg syndrome of the belly, which is to say that it's a illness that we don't understand. I have no doubt that it's very painful for the people that are undergoing it, and it leads to some vomiting. The next question is, does it have anything to do with marijuana? In my opinion, no. Although there is, that's like sort of an in vogue thing. Seems like everybody in America is smoking weed anyway. So I think they even noted that. Therefore, it's associated with everything. And then, what do you do with it? And I think the answer is you treat these people humanely. You treat them with narcotics, and then and then tell them, do whatever you can to try to get them into a longer, better treatment program to avoid exacerbations and to manage the exacerbations at home, but while leaving the door open for return visits.
think
And
we
I
should
don't
be-
give a lot of outpatient management for these types of folks.
Where did this diagnosis exist 10, 20?
Didn't.
You called it intestinal angina or something. I don't know.
Yes,
No, it
exactly.
didn't. So there are many things like that, like chronic fatigue syndrome, like fibromyalgia, like we used to call it neurasthenia. So I would say a couple of things. One is that it's undoubtedly true that many people who come in with these very sort of bizarre things that we never used to have, they're probably depressed. That depression probably is the underlying basis for many of this. But at the same time, I couldn't agree more with Mike that we should be humble. Just because we don't understand, that doesn't mean that it's not real. There are things that are real that we don't understand. There are lots of examples of them where we didn't know about it. Now all of a sudden, where was AIDS before 1980? And then all of a sudden it was, the most important disease in the world. It didn't exist before. So just because we don't understand it, we should be we shouldn't be arrogant about that. And then finally, we should be tremendously circumspect about judging other people and their suffering. And we should treat that. We should take care of them to the best extent we can. If you think somebody's depressed, try to get them help that way. But one of the great things that we do in the ER is we treat symptoms and we make people feel better. And we, unlike a primary care physician, which I think is a fabulous job in many, 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 many ways, but I always feel really good that I don't have to do that. I don't have to live in a world where my number needed to treat is 50 or 100 or 200. My number needed to treat is mostly 1. I can make almost all of my patients, give them relief. And to me, that's tremendously important. So I don't understand a lot of these things, but I try not to be judgmental, and I try to help the patient as best I can.
We see this revolving door of patients with this, and I wonder if
Right.
the problem in that they come in for very strong medications that make them euphoric.
That's a hugely difficult question that would take a long time to answer, but I think worrying about that actually is not a good idea. I think we do more harm by pretending we know which patients to fix and which patients not to fix. And we're not going to make that problem. If they are depressed or they have some other problem, we're not going to cure that by saying no. It just doesn't work.
I always find,
But are we presenting part of the problem for some people?
Maybe, but I think we're being...
Comes 3 times a week, and the only way they ever feel better is with their Dilaudid.
Right. So I think that you know, there are occasional outliers that are really, really difficult to treat. And they're the ones that come in every day and all those things. And I think that the onus on us in those contexts is to try to integrate with some kind of outpatient.
Long-term care.
Long-term.
Outpatient. And so that we can start to, you know, at least have a cohesive method so that it's not arbitrary. Because what I find is a lot of the time that people are, when this is happening, they came in on Monday and the person gave them a Vicodin, even though they've said that doesn't work at all, right? So then they come back on Tuesday hoping for a different doctor, and then that doctor maybe gives them something different or maybe doesn't or whatever, and then finally they come in and by Thursday you're really frustrated with them. And really what we've done is had a non-coherent plan that encourages people to return repeatedly, actually, in hopes of finally finding somebody who'll treat
This
them.
is complicated, and I think we would need a half hour to go over it, but I would just suggest to you to think that, first of all, in the U.S., it's any 13-year-old can get narcotics on the street. They're easy to get. We're not going to solve the problem of somebody who is addicted or needs medicine by saying, no, you don't get it in the ER. In fact, the worst thing to do is have them get it on the street by knocking over some old lady. We don't solve it that way. There are many people who really have pain and need us, whom we punish because we're so worried about the one who's doing the opposite. If I were czar, I would make narcotics available to people who need narcotics and save so much money with all this interdiction and craziness and save all of our worry and time and am I being abused and all this stuff. Get that out of our practice. And that we could spend a lot of money on actually helping people who are addicted. We could have rehab programs. We don't do any of that because we spend all our time being punitive. And not only does it not help the people who are addicted, but it really punishes the people who need our help. I think that, to me, I'd much rather overtreat 12 addicts than undertreat one person who needs pain medicine. And I think we do it just the opposite way. We undertreat 12 who need the medicine because we're so worried about that one potential addict. I think that's the wrong way to think of it.
All right,
And the winner is?
The winner is, and rules are, must be present to
Must be present, absolutely.
Cynthia Wickelman.
She's here.
Oh my God!
this is set up. This is set up.
I've never won.
We'll take care of you
We'll
after.
take care of it. Bye.
I've never won anything.